Good morning. Can you guys see me?
Good morning, Greg. Yes.
Jerry.
Yes.
How's that?
Happy New Year, Greg.
Thank you so much. I'm going to pull up my screen here, see if it'll share. Do you guys see the beginning slides?
Mm-hmm.
Yeah.
Yep.
It's AIS Technique.
Mm-hmm.
Excellent. Good. Let me give it just a couple minutes here and make sure we have everyone logging in. That's okay. All right, one more minute and we'll get started. Can you guys still see it? Doesn't look like it's screen sharing.
Yeah, no, it's not.
Yeah.
All right, here, I'm gonna do it again. Here it comes.
I can see it now.
You're up.
Mm-hmm.
Cool. All right. Well, good morning. I know I've been out of commission for a couple weeks on vacation and I'm returned fully energized. So good to be back and good to see everyone on this call again. So special hello to Jerry and the team in Italy. I think he's got a room full of some residents and maybe some attendings, and welcome guys to our lecture series. Today we're going to kick things off by basically talking a little bit about the technique of idiopathic scoliosis correction. So it won't be so much about the classification, et cetera, but a little bit more of the details and nuances to, how to safely treat some of these kids that have these spinal deformities. And so it'll be a little bit more technical rather than theoretical. So that's what the plan is for this morning. So good. So without further ado, we'll just start with a case, and we'll probably basically just walk through this whole case as we currently see it. So here's a girl that has this deformity, is about a 60 degree right thoracic curve. And you see in the sagittal plane seems to have a relatively normal sagittal profile with all things considered, including looking at her L1 and T4 pelvic angles. And she does have a proximal thoracic curve of about 32 degrees, so that will be relevant as we look at this. And when she bends out to about 28 degrees up top and is, I would say mildly flexible or moderately flexible in the thoracic spine. So looking at this, I would likely put her in the classification where she has both a proximal thoracic and the main thoracic curve. When it comes to treatment, if you look at her lumbar curve, she definitely straightens out pretty darn well in the lumbar spine. So when we're thinking about where we start and stop, if you look at her LIV, the neutral vertebrae is around L2, and that would be probably a good stopping place given the fact that her central sacral line bisects the pedicles at L3, but then still touches it at around L2, so we'll call the last touched vertebra L2 as well. And you could argue maybe L1 in this, but L2 would be pretty safe. The end vertebrae of the cob is T12, maybe L1. So I think when you put all three of those together, and given her age, she was a little bit older. I think she was 18 when she had surgery. So those things kind of say, LIV probably should be somewhere around L2. The UIV, she lives with her shoulders pretty level, her clavicles are pretty level, and we do know her upper thoracic curve was a bit structural when she did her bending. So those are things to keep in mind. In the sagittal plane, a couple things we want to take note of is what's happening at the thoracolumbar spine, especially if you're trying to cheat the system and stop short at like T12 or L1. Then you'll want to know what's going on down at the thoracolumbar junction, because you don't want to stop in an area of kyphosis. And then again, just as we're thinking about things more, especially in the adult world with spine shape, I do think it's important to keep that in the back of our minds as we recreate a sagittal plane for these kids, that we also restore the appropriate spine shape to them. So when we get to the operating room, we'll do just a typical exposure. Your goal here is to keep blood loss pretty low. A couple things about exposure that we do. One is we do hypotensive anesthesia. So as long as we get a good baseline motor and things are okay, we'll quite classically keep the blood pressure pretty low. It means systolics usually in the 80s or 90s. And that'll keep the bleeding to a minimum. We use tranexamic acid, and then the kids we use a high dose, which would be 100 milligrams per kilogram loading, and then 10 milligrams per kilogram as the infusion for the duration of the surgery, and then we just continue it at the end. And then we use a few other things to try to avoid bleeding, and those are things like the Aquamanus, stuff like that, to keep passive oozing to a minimum, and then use cell saver in general. I think if you're doing a more of a selective fusion, or if you're only doing 6 or 7 levels, then I think cell saver is definitely not needed, as the chance for transfusion in these kids is pretty darn low. Then once you get exposed, before you get the whole exposure done, you always want to check a level. If you're crossing the thoracolumbar junction, things can get a little easier because you can feel a transverse process, for instance, and that'll give you some sense of whether or not you're at the right place or not. But checking levels is really important, because you really don't want to extend the fusion because of an error in that world. And Dr. Barney always taught, always preserve all the facet capsules. Just be gentle with the tissues, because even if you expose a part of a vertebrae but you haven't taken down a facet joint, for instance, then there's certainly a good argument that you don't need to fuse that at all. So just a few nuances there. Other things in scoliosis, make sure you count ribs and make sure you count lumbar vertebrae, and then don't be afraid to check both APs and laterals if you're uncertain. Like, those are really important things. So you always like to say, okay, where's the where's the last rib, for instance, and then I'll try to cross-reference that with where the LIV is, and then on the fluoro, then use that as my guide. I also think it's a really good idea to check it both at the top and the bottom in these cases. When you're doing a C2 to T2, the C2 is pretty obvious. When you're going down to the pelvis, it's pretty obvious where the pelvis is, or S1. But when you're stopping in the middle of the spine, it can get a little tricky on your levels. So just be aware of that. Exposure should be subperiosteal. You should have a really nice, clean spine when you're done. You should be able to see everything that you need to see the exposure, especially if you're doing open pedicle screws. You'll want to see the facet joints nicely outlined, as well as the transverse processes. You want to see from the tip of the TP to the tip of the TP. That's a good rule, so that you can safely place your instrumentation, which is going to be the workhorse of how you're going to get the scoliosis corrected.
Recording.
We then typically use the Misonics to cut out the facet joints. We do inferior facetectomies with these. Is the video presenting, guys?
Yes.
Yeah.
I can see
Okay,
it.
good. So, the bottom line here is that you're just trying to get the superior articulating process, the cartilage exposed there. And so you just take down the IAP at all these. Now, some would call these osteotomies. I don't necessarily, I think it's part of releasing the spine. So I do think there's a long continuum of releasing the spine, and this is certainly one part of it. But when you talk about things like billing and things like that, I wouldn't necessarily say everywhere where you do an IAP resection is necessarily an osteotomy. To me, it has to do more with where you're intending to release the spine to do the correction. But this is definitely a way to get things to be looser up and down. I like the Misonics as well, or this tool, or any type of bone scalpel type tool, because it does reduce the bleeding across this level. It takes a little bit more time, as you can see, than taking an osteotome, which is probably a bit faster. But these are really clean cuts, and definitely, I think, reduce on the bleeding some. And so this is what it looks like after you've done those cuts all the way across it. And then when you take the facet joints off, when you take the IAPs off, you can see the facet joint exposed. You see the nice, pretty cartilage there. A couple things on the technical nuance, because a lot of times you're passing this bone off, but you have to realize that the bone you just passed off, the undersurface of it, is also articular cartilage. And so the techs need to know, if they're the ones that are preparing the bone, or if it's residents preparing the bone, they need to be aware that you have to take that cartilage off, because cartilage isn't going to do much for bone effusion. So same thing here, you'll want to get a curette onto these, and that's what we're doing here, is just taking a curette to all the different facet joints and taking the cartilage off, just to make sure that you have exposed bones, so that when you go to decorticate it later, you're literally getting a nice bony surface for fusion. So really, really important, I think, on the technical side of things there. So this is when we go to the next level of release, and you can see here where I'm cutting the the superior articulating process, and we've taken down the interspinous ligaments here. So we've taken down part of the spinous process already. We've taken down part of the interspinous ligament, and now here we're taking down the superior articulating process. And the idea here is that you're, again, sequentially releasing the spine. Now, depending on the flexibility of the patient, you might need to do this bilaterally, or you might need to do this bilaterally in combination with taking down the ligamentum flavum at every level. And you can see here the ligamentum flavum is actually still preserved in this environment. So this cut is simply going from a point, I would say about halfway up the IAP, and just cutting it across, and you're releasing this tether in the back. And again, I think the main thing is to assess flexibility, to say, hey, have I done enough for me to be able to get this spine corrected to the shape that I'm desiring with these releases. And so you can see this goes pretty quick relative to taking down the ligamentum flavum and then having to cut out of each IAP. And the other reason I like to do this is because it leaves the bone in there for fusion. So you're not necessarily taking all that extra bone out, and every time you take that bone out, it bleeds. And so I like doing it this way because it releases the spine and really keeps things pretty dry. And so here's just kind of a a picture version of what we're doing. Again, just kind of releasing these IAPs up and down. So if you look at this, the number of fascicectomy levels, there was a correlation between the ability to achieve kyphosis through the spine. So I do think that's important. And so I think you need to understand ahead of time if you have a really lordotic thoracic spine versus a relatively normal one. And so in this case, she had more of a coronal deformity. Her thoracic spine in the sagittal plane did not look very bad. And even when we opened her up and looked at her, in real time, there was really not a terrible amount of lordosis throughout her thoracic spine. So for that reason, I don't think I needed to go bilateral here or take everything down. I didn't really need to lengthen the posterior column as much. So just know that if you need to create a lot more kyphosis, that you'll need to do a bit more work. The good news about doing it this way as well is that you actually have the ability to collect a bunch of bone. Like I said, just be aware of that process, and make sure that your techs are aware that they should be preserving as much bone as humanly possible, and that they should be taking the cartilage off of it. The next part is placing screws. We're not going to talk too much about how to do this, except if you're doing it freehand. I like to do this by level. I like for each a surgeon to kind of be working at the same time, so you can triangulate your screws. I don't think you necessarily need screws at every level either, and these are things that you can plan out ahead of time to skip screws in certain places that you may not necessarily need fixation at outside of the foundations and maybe across the apex on the concavity. So once the screws are in, you'll get a better sense of like how everything lies. Now, the types of screws you use can matter as well, and in general, I like to use uniplanar screws. Uniplanar screws allow for some flexibility in the sagittal plane, but then in the coronal plane are pretty darn stiff. And what that does, it just kind of aids in the reduction of the deformity, and so it makes life a little bit easier when you're trying to get this all reduced. So these are all uniplanar screws that we place top and bottom. That's kind of what it looks like from the top, and with the spine released the way it is. The next thing we're going to do is, I don't think that was a video, no. The next thing we're going to do is place our concave rod. And so there's always arguments on which rod to place first, but again, this is just simply my technique. There's numerous ways to do this. I'm just showing you kind of what I like to do. This is basically putting the concave rod in, and I get it attached to the spine, both inferiorly and superiorly, or cranially and caudally, with these reduction towers. You can use things like reduction screws too. Those work fine. Every system sort of has its own nuances. I would just say, just understand your nuance. So here's this concept of what we do with the concave rod, though, which is we, in general, like to overbend it so that there is a large space between the apical screw and then where you're trying to pull the spine to. And so the idea here is that you're doing a couple things. One is that you're actually pulling the spine from its lordotic orientation into more into kyphosis, and that's probably the primary goal here, is to really pull the spine out. Now we know that there's also some flexibility in the rod, right? Like every rod has its limit, and even using 6.0 cobalt, for instance, that rod will actually unbend as you reduce the spine because you're fighting these different forces. So doing this this way at least allows you to try to achieve as much kyphosis creation as possible. So here's this desired final rod shape. Let's say in your brain you're like, okay, this is kind of what I want it to look like. And then if you're thinking about using like a cobalt chrome, you're going to want to do something like you see here with the red rod, which is you're going to overbend it to try to accommodate for the fact that the deformity is going to flatten it somewhat. If you're using a titanium rod, you really need to overbend it because this thing is a lot more flexible and will definitely unbend as you put it in. So just conceptually, as you think about how you're bending these rods, this is one thing to just remember is that there's the flexibility within the system that can be problematic. Okay, so this is the rod having gone in. I actually like to use the hex driver at the coddle part of the rod, so that you leave that little hex piece on the rod, and then you can actually control the rod better. So nowadays I'll leave that hex on there. But you can see here as we reduce the rod to the spine that you're getting a partial reduction here of the scoliosis, and then of course our main driver is to try to pull the spine out of lordosis here, and that's sort of the process that you see happening and going across here. And we'll fast forward a little bit. And then I usually put some set screws in there to lock it, not lock it, but hold it in place. I usually leave all the set screws loose. And then once you derotate that rod, you can see that we've now straightened the spine pretty nicely. So the scoliosis is relatively well corrected, but if you look at the left side of your screen or the right side of the patient, it's still elevated quite a bit relative to the left side. And that's because that rib prominence is still pretty high. And because of how the rod was placed, you haven't entirely derotated that spine. So this is where differential rod bending matters. And if you look at what we're trying to achieve, you're going to try to cantilever the right side or the convexity to try to diminish the rib prominence on the right side. And the idea here is that you're going to have a pretty flat rod. And that flat rod, you want the intersection. Let's see if I have that. Yeah, as you push down on the rod, you want the moment to be exerted at the apex of the kyphosis. Excuse me, not the kyphosis, of the apex of the rib prominence, which you can see here is right about the middle of your screen. When you push that rod down on the right side, you'll see that it's exerting its force higher up, and then you basically just cantilever and reduce that down. So the next step, if you want to do this, is a direct vertebral rotation. And to do this, you have to find your neutral vertebrae, and you're going to lock the neutral vertebrae in place. And so the towers that are on the far end of the patient, or the caudal side of the patient, those are at the area of the neutral vertebrae. And so what you're doing is you're triangulating the screws. And so you're connecting them by the vertebral body anteriorly, and then you're connecting them posteriorly with these bars, basically, that are now making the two screws into a single unit that you can then lever off of. And the idea here is that you're going to sequentially derotate these, and it looks like I'm showing you how to do this nice and smooth. Once you clip these on, you tighten them in place. And then now you're able to rotate one vertebral body relative to the other. Now you can see that my left hand is rotating over the top, but if you look at my index finger, I'm actually lifting the vertebrae out of the patient. And so what we'll do here is you're rotating this. You're not necessarily going in a flat plane. You're actually trying to lift the spine out. But you can see how these are now really well aligned in the coronal plane. And when I do this, I usually over-rotate it by maybe 5 or 10 degrees because I know that there's a little bit of flexibility in the system. So in theory, we've now made the next level the same as the neutral vertebrae. And so we'll do the same process all over again, where you move up the spine, connect the next level up, and then you rotate the next level relative to the first. And so we'll usually do this all the way up to the apex, or even consider going into apex +1. So, and then just to show you again here, you can see how we go past point a little bit, tighten the set screw. I'll do my side, and then when I release, you'll see that we've just about got these towers pretty even. So, and then just keep going up the spine until you hit the apex. What that does is it takes that rib prominence again and flattens things out. You can see here in the two images, just looking at how doing the differential rod bending, as well as the direct vertebral rotation, that you're able to get that to look pretty good. You can fine tune with a little compression distraction. I do like to do this. One of the main reasons is because we try to place the screws pretty meticulous. And the idea is that when you're done, if you've picked the right LIV and UIV, that you should have created a bunch of rectangles throughout your spine. And if you look here, things look really symmetric all the way up and down. And that's kind of the idea of what compression distraction does at the end, is it kind of just fine tunes the correction a bit. But you can see even here that the spine corrected really nicely. We didn't have to take the ligamentum flavum down at all these levels, and we're able to, keep a layer of protection over the spinal cord, which I think is not a bad thing at all. You can check it with a T-square afterwards. I would say I don't always do that in the AIS world. I feel like if you've picked the LIV and UIV correctly, you should be in pretty good shape. Just to show you here, though, if you check it, you just want to make sure you're hitting it up between the uprights at the UIV, and allow for some auto correction to occur as a result. Then doing a meticulous closure is obviously important, and then checking your post-op X-rays. And so here she is at her 2-year follow-up, and had a really nice radiographic result. We got her kyphosis restored, her L1 T4PA looked pretty darn good. They weren't too off ahead of time, and things look pretty good there in the coronal plane. I have a few minutes. I'll just show a case from right before Christmas. It was actually in a little bit of an older girl. She was 21. But she was stiffer than all get out, and she's a competitive well, I shouldn't say competitive. She's going to school on a ballet scholarship. So, sorry, she's 19. She started being braced at a young age, and for whatever reason, they decided not to treat her. You can see her deformity is a bit more pronounced than the last girl's. And here she is in the sagittal plane. Here's her films in 2015, 2019, and then 2023. You can see that there's a significant progression of her deformity over time. And obviously very reasonable to brace her in 2015. And 2019, it would have been a little bit more ideal to start thinking about surgical management. But the family and the patient also decided to wait on that. So she has an 80-degree curve now, and has both thoracolumbar and proximal thoracic curves to go along with that. Her T4 and L1 PA don't have much of a mismatch, which in this age group is pretty common. And then here we are at supine and standing, and you can see there is a lot more stiffness in this patient than we saw in the last. And so we're going to call her a triple major or a lanky 4 because she's got structural curves throughout. Now, typically, you might want to include the lumbar curve, but because of her history as a ballerina, we decided not to. She also had pretty bad pedicle anatomy, especially in the right upper thoracic, in the proximal thoracic curve. Pretty bad pedicles there. So on this patient, what we ended up doing is doing a little bit more selective work. So here's kind of where we had her in the operating room, and she looks very similar after surgery as well. So we got the main curve reduced to about 30 degrees, which is kind of what you'd expect. But we had to work really, really hard on this one. I don't have the intraop images, so I apologize for that. But and I can update the slides for next year, I guess. I think I have some. But we ended up using a planned rod for this one. So we had the rods delivered to us via UNID, and I was actually really happy that we did it because the rods, instead of me bending the rod, these rods were created with the bend in them. So the rods that are delivered to you have never been bent, and I think there may be a strength component to that is very beneficial. It definitely wasn't her. So I had them actually send us 2 of the concave rods and 1 convex rod. The concave rods, I actually had to switch out. I put the concave rod in, did it exactly like I showed you in the last video. But then after we did the convex rod, I actually took the concave rod out, and I wanted to show. I need to show you guys. I apologize, but like there's a dramatic difference about how much this rod actually flattened out. And so we actually put the second rod that they had sent in and got a bit more kyphosis correction out of it. So just to show you that some of these really stiff spines, she ended up getting bilateral releases, ligament and flavum taken out, and even with all that, she was still just extremely stiff. But the final result looks pretty good. So awesome. 7 o'clock, I think we're on time here. Questions from the group?
Thanks, Greg. That was awesome. What do you think about, when we get the patient-specific rods, are you able to get them one overbent and one underbent?
Yes.
Okay. Yeah, that's huge.
Just
That wasn't the first iteration of those,
Yeah. You just say like, hey, I want it overbent by 20 degrees with the apex at T9. And then they'll
available early on, and that's a huge benefit. I'm enjoying that option as well.
And how is that better than guessing if you're getting deflection of the rod anyway for $3,000 less? Just curious.
Yeah, it's a great question. I don't know if it's better or not. I would assume, I will tell you that the rod is definitely stiffer than my usual 6.0 cobalt. Because even a 6.0 cobalt, I can sit there and bend. But this one was I felt like it was almost unbendable. So I thought the strength of it was better. But even with that, I think I was showing you in that case, even despite that, like we were still flattening the rod, doing the reductions. I mean, it's crazy.
Impressive, huh?
Awesome.
Thanks, Greg.
Good.
Well
It's
done.
7:01. We're on time. We'll keep it that way. You guys have a great week, and we'll see a lot of you tomorrow. So.
Thanks, Greg. Bye.
Welcome back.
Thank you.
Thank you.
Thanks, Greg.